Hi, and welcome to this clinical case on colon cancer. So let's jump straight into the case. We have a 70-year-old male presenting with a 3-month history of fatigue and weight loss, with more frequent opening of bowels. The patient is cachexic and anorexic, and on colonoscopy, we find adenocarcinoma, we find mucosal lesion at the descending colon, and the biopsy shows adenocarcinoma, which extends through the muscularis propria. Histopathology confirms 2 lymph nodes are involved, yet there is no distant metastasis. Which management plan is most suitable? So, what do we have? We have an elderly male who is presenting with constitutional cancer signs and symptoms. He's got fatigue, weight loss, cachexia, anorexia, and now we also find on colonoscopy there is a mucosal lesion at the descending colon. This is exophytic, by the way. And we now know there's adenocarcinoma. And why is this important that it extends through the muscle layer? This is important when it comes to staging this cancer and the treatment. Histopathology confirms lymph nodal involvement, which is also important. Remember, whenever we have 1 to 3 lymph nodes which are involved, this would be considered stage 3 or Duke's criteria C. Duke's criteria C. Which management plan is most suitable? Obviously, this is a confirmed case of colon adenocarcinoma, and we can work out the Duke's criteria. So, the treatment is a left hemicolectomy and post-op chemotherapy. We're going to give this patient chemotherapy because there was mention of lymph node involvement. Whenever lymph nodes are involved, we start to treat with these chemotherapeutic drugs. Left hemicolectomy, why is this the appropriate surgical treatment? Because tumours of the distal transverse colon or the descending colon do typically require a hemicolectomy, and if you just imagine, here's the cecum, here's the ascending colon, the transverse colon, the descending colon, the sigmoid, the rectum, and the anus. So here, if it's up to here, this would be, so this is the patient's right side and this is the patient's left side. If the cancer was found here, that would obviously be a left-sided hemicolectomy, left-sided excision of the hemicolon. Patients with Duke stage C, which means involvement of the lymph nodes, should be offered adjuvant chemotherapy and not radiotherapy. So we typically do reserve, let me just tell you here, that we do typically reserve the radiotherapy for rectal cancer, so R for R, and we typically do give the chemotherapy for your colon cancer. So how does Duke's criteria progress? So Duke's criteria is a classification for how far the tumour has progressed. So if the cancer is confined to the most superficial cell layer, it's Duke's criteria A. If the cancer has invaded through the wall, through the muscularis, that's Duke's criteria B, as long as there is no lymph node involvement. Duke's criteria C is it spreads completely through the wall of the colon. The cancer may extend completely through the wall of the colon, and most importantly, it's also spread to the lymph nodes. And Duke's D is D for distant metastasis. It can spread to the liver. That's why we want to do a CT scan. CT scan specifically to check for liver metastasis. Duke's A, when it's just superficial, the treatment is usually surgery, and the 5-year survival is quite high at 95%. Duke's B, again, it's just surgery, but as soon as you go to Duke's C, which I told you has lymph node involvement, now you're going to give chemotherapy as well, and radiation reserved for rectal. Now the prognosis jumps down to just 1 in 2 patients surviving the 5-year rate. Duke's criteria D, now you're going to give surgery and chemo. So just one more quick way of remembering Duke's criteria A was that the cancer stayed within the bowel wall and not yet invaded the muscularis or the muscle layer. So A for adjoined to bowel wall. A for adjoined to bowel wall. B extends beyond the bowel wall through the muscularis. It invades the muscle layer and now it's beyond. B for beyond bowel wall. C, remember this is the crucial one which determines chemo, and you can do a preoperative lymph node investigation, preoperative chemotherapy as well if you want. And C is for contiguous lymph node and C is also for chemotherapy. C is for contiguous lymph node involvement, and C is for chemotherapy too. And finally, D is for distant metastasis. Distant mets from the colon to the liver, to the lung, anywhere else. And moving on. About the case we just discussed. So depending on where the colon cancer is, that's what will govern the treatment. But mainly, the treatment for colon and colorectal cancer is actually surgical resection plus or minus chemotherapy. Now, surgical resection, how will you do it? Well, like I said, if it's a cancer of the cecum or the ascending colon or the proximal part of the transverse colon, we will do a right-sided hemicolectomy, because these are on the right side, aren't they? Okay, right-sided hemicolectomy. If it is a cancer of the distal transverse colon, distal part, or the descending colon, we will do a left-sided hemicolectomy. And if it's a cancer of the sigmoid, we will do a sigmoidectomy, and these will all be laparoscopic. Now, if in any case there is extranodal involvement, any lymph node involved, we would then do a chemotherapy as well. So is there preoperative chemotherapy indicated? Only in the case of metastasis or spread to the regional lymph nodes. But mostly we will continue with postoperative chemotherapy, which is adjuvant. Okay, so this would be to high risk stage 2 or 3 disease. Okay, stage 2 or 3, which means that there is local invasion with or without lymph nodes. And stage 2, and stage 3 is spread with regional lymph nodes. Why? So this is the Duke's criteria, and why is the Duke's criteria so important? Because it governs whether patients are high risk or low risk. It also governs the treatment approach for this colorectal cancer. So let's see, stage 1. Stage 1 is where it's confined to the bowel wall. So I like to remember it as, this is also, by the way, this is Duke's is in A, B, C, D. So this is Duke's A, this is Duke's B, this is Duke's C, and this is Duke's D. So Duke's A is when it's adjoined to the bowel wall. That's how I remember it. A for adjoined to the bowel wall. B is beyond the bowel wall. Beyond, B for beyond. So this is now invading through the muscular layer. You can see here it is. A or stage 1 is not yet invaded to the muscle layer. And stage 2, it has invaded the muscle layer. Stage 3 always means that lymph nodes are involved. So for C, this is Duke's criteria C. So C, contiguous lymph node involvement, contiguous lymph node. And D for distant metastasis. Stage 4 for distant metastasis. So this is for the TNM kind of stages, but also the Duke's criteria would be A, B, C, D, right? So that's how the Duke's criteria would be. I don't have another picture. Also here is a nice mnemonic for colon. C is for cachexia. O is for occult bleeding. These are the colorectal carcinoma symptoms. C is for cachexia. O is for occult bleeding, such as melena. L is for loss of appetite. O is for the bowel outputs changed. And N is for no interest, such as weakness and malaise and anemia. Now, what if you had a patient with rectal cancer? So when it comes to patients with rectal cancer, you can do
two surgical resections. You can do an anterior resection, which is from the top, or an abdominoperineal excision. And what governs this? It depends on where the cancer is. Is the cancer more than 8 centimeters? So this is the rectum and this is the anal canal. It depends on 8 centimeters. Is the cancer more than 8 centimeters away from the anal canal? If your answer is yes, then you would do an anterior resection. Or if the cancer is in the proximal 2/3 of the rectum, the proximal 2/3. And then in what case would you do an abdominoperineal excision? By the way, that is the one that's known as the Miles procedure, isn't it? That's the one known as the Miles procedure. So that is when the cancer is less than 8 centimeters from the anal canal, okay? And that's when you would do an abdominoperineal excision and the patient would have okay, that's it for this video.